well, for a minute as I get set up for first.
Talk a minute.
Talk.
Well, you know I can talk.
I know.
All right. So I am really, really excited to have the stroke chimers here today. They're some of my most favorite people in the whole world. They are some amazing, amazing stroke survivors that have come together to spread their talent and their passion for education about stroke, and to show just what we saw today: never give up, that stroke survivors never quit, that they keep on going, and they learn to do new things. And they're just a wonderful example of that whole stroke survivors never quit and learning to do new things. This is something that came out of our stroke camp. We had these one-handed chimes, and we do a lot of music in camps because, as you know, a lot of stroke survivors who are not able to speak very well can sing. And Randy has some aphasia from his stroke, and he's actually going to sing today. He has a wonderful voice. We do have, no, he doesn't. He does. He can sing Elvis like nobody's business, I'll tell you. But this came out of stroke camp. We used a lot of chimes, and Mary Lee and I were talking with her, we're like, we need to have a choir. We need to get these people out. So I sort of started out being their booking agent, and I still sort of am, but I just love to get them out and for people to see them. They're so inspirational. They're just so amazing, and it's just, I think it's just the most wonderful thing for them to get up here, even with the challenges that they face, to get up here, to learn how to do this, to concentrate on this, to just share their talents, to share their experience, and to share their passion for education for stroke. A lot of these stroke survivors also go out and do 5th grade stroke education with us, and so they are really giving back to their communities, and it's just totally amazing. I'm just really excited about them. I never get tired of hearing them. I never not cry when they play, so if I'm up here sniffling, you'll know why. But I want to present to you the Chime Strokers. And I hope you enjoy them and love them as much as I do.
Thank you, Jan. She is our biggest fan, and she was our booking agent for especially the first year. She told us that, hey, get you in the hospital. My name is Susan Bach, and this is Lauren Kramer. We are both board-certified music therapists. We have worked at stroke camps. We have music therapists at every stroke camp that we put on, thanks to Mary Lee, and she'll probably say a little bit here later. This is our 5th year of performing as the Chime Strokers. And we go out into the community and we perform mainly to bring awareness to stroke and the stroke survivor. So we'll show you in a little bit about how we actually do the fast awareness. But we want people to see that people with stroke can do things like this and enjoy music and have a purpose in the community for that. So we're going to play some patriotic songs for you first. And I'll talk a little bit. Lauren changes the chimes, and I usually do the talking. Do I have any musicians here today? People who play piano or any instruments? Piano, okay. And violin, okay. Anyone else? You play piano? Guitar? Okay, all right. So these chimes are just like the notes on a piano. So you have white notes and black notes, and you'll see the white chimes and the black chimes. And so our different songs are in different keys, and we will change the chimes for that. And then I will explain. We also use some charts, and I'll explain that a little bit, just to give you an insight into musically what we do. But our first song is God Bless America. Okay. places that play the bells. So it has a similar sound, but this is a different instrument. And in playing this instrument, there are actually, it's a two-step task, which contributes to the rehabilitation in motor planning. And so you play this just as if you were hammering a nail on the wall or casting a fishing pole like that. But as you can see, it will stay ringing until you stop the sound. So when we go from note to note, the chimers have to remember to stop their sound. They play when we point, but then when we go to the next person, they have to stop the sound, otherwise you get all these notes playing together. So for our new chimers that just joined, that can be quite a challenge because they have to remember that second step, with that. So in that way, it contributes to their rehabilitation cognitively because that's something that they have to learn to do. Our next song is My Country 'Tis of Thee. You'll see sometimes that we use a chart, and these charts have colors on them, as well as our chimes have colors. And for those of you that play guitar or piano, these are chords. So every chord has a color associated with it, and then the notes in that chord, we put the colors onto the chimes. So another task that they have to do is that when we have a chart, they play only when that color is up on their chime. So it's another attention task that they have to do. So we do both. We use the chord charts because Lauren and I only have 4 hands to make 4 notes play at a time. And when we use the chart, then we can use the full range of the chord and the full range of all the chimes that we have. Our next song is America the Beautiful. Are any of you familiar with music therapy? Only one? Have you heard of music therapy? Okay. As I said, Lauren and I are board-certified music therapists, and so that gives us the ability to know how to work with people with different needs. And as a music therapist, we create music experiences to work on therapeutic goals in a clinical setting. Are there any music therapists in your facilities where you work? I know, that's sad. It's one of the greatest jobs. We have lots and lots of fun. And some people think, oh, that we just, play music for people. But we have people make music with us. We create a music experience, and we use active music making. As you know, you may or may not know, music uses both sides of the brain. And so when there is a brain injury, whether it's stroke, Alzheimer's, they can still use music because music can bypass that damaged part of the brain. So someone with aphasia that cannot speak fluently may be able to sing fluently. And I mean fluently, if it's an overlearned song, something like that. So we like to incorporate music therapy in our stroke camps and as well here. And I'm going to set up the chimes, and you can talk about fifth grade.
I know Jan has probably told you many, many things about stroke camp, but how many of you know about Retreat and Refresh Stroke Camp and the camps that we do? Okay. So Mary Lee, Nunley, her husband John here, had a stroke in 2001. And in 2004, I guess she could tell though.
No, go ahead.
In 2004, she did a weekend camp for the local support group in Peoria, Illinois. The next year they did 2, and then they did 4, and then became a nonprofit in 2007, and have now done 107. A lot, over 100 camps since 2004. We did bring some brochures if anybody wants one of these that talks a little bit more about camp. There's a reprint of a newspaper article from a camp that happened in Iowa a couple of years ago on the inside. But the weekends, it's a 3-day weekend camp, Friday, Saturday, Sunday, focuses on education, socialization, relaxation, and support. It is for the survivor and the caregiver, both. The volunteers that come from the hospitals, PTs, OTs, nurses, speech therapists, all of the different disciplines, to give up their time. Jan and Teresa, there's Teresa. Jan and Teresa have been helping out for many years, and Jan's one of our best skit coordinators at our campus that she goes to. There's another flyer here that we brought. This has more detailed information about camp, so we'll leave some of these for you if you want to take a look at those.
Right? Our next song is Heart and Soul. Introduce themselves. I think we'll start over here.
I'm Carol Lee. I'm a volunteer for the stroke group, and I'm also a caregiver.
And I'm Sue Johnson, and I had my stroke March of 2010.
I'm Bill Hart, and I had my stroke December of '05.
I'm Marita Burlett, and I had my stroke 5.5 years ago.
I'm Ruth Ann Scott, and I am a caregiver for my husband way down there with his thumb up in the air. He had his stroke October 22nd of '08.
This is the Bob that Gail was referring to earlier, at the Cardinals game, thrown on the first pitch. You're famous.
I'm Eugene Wandel. I was 4 years ago.
Pat Ozella, 14. Thank you.
I'm John. I had my stroke about 14 years ago.
You did. I had a stroke, I was there for that. I was there, I remember too. Mary Lee Nunley, I am the founder and the executive director of Retreat Refresh Stroke Camp, and I'm typically not a chimer, but I'm a chimer today because we had some illness and we had to do some quick shifting. So thank you for having us here.
Yes. I'm Bob Scott. I was with my wife down here. Right there. And everything turned out pretty good. Yeah.
Tony Ozella, I'm Pat's husband and caregiver.
Lorraine Roman, I'm Randy's caregiver.
And she's graciously filling in for us today also.
Yes.
So one of the, when we perform, one of the things we do is bring stroke awareness, and we pass out the, fast cards. And so what I do is I pass out the little fast cards, and I have people buddy up, and we go through the FAST, and I actually have them do that. So, you all know it, so I won't have you buddy up. But we put some music to the FAST to help them remember that. All right, so the first one is face, and I think you'll see the correlation here. Raise their arms and just practice that, with each other, just to give them a little bit of experiential. And we do a lot of community and a lot of nursing homes as well. There's families with the nursing homes. So you must remember this. A stroke must not be missed. Remember to act fast. Call 911 with no delay as time goes by. And Randy, and I'll help you sing. This is orange, faded orange, not yellow.
You must remember this, the stroke must not be missed. Remember to attend. On 911 to dial daily as time goes by. You must remember this, the stroke must not be missed. Remember to attend. On 911 to dial daily as time goes by.
Our soloist is one of the individuals who is ill today, and Monica Montevero, and she has a beautiful voice. And there's one thing you can't replicate with a bunch of chimes, and that's a beautiful voice. But luckily, we have the song that we're going to show for you now for you to watch on video. It is a song called Let Me Do, and the words, the lyrics of this song were put together at a camp by a music therapy student and another volunteer who had a kind of an inspiration in the night. And so it came from what stroke survivors said in their discussion group. And that is, what would you want the world to know? What do you want society to know what it's like living with stroke and being with stroke? Those words were shared, and we were just going to kind of read them back, and the song came from that. So it's an original song, and what you're going to see here, it's being performed by the chimers with Monica singing, and this Monica Best-Wheeler, put together a slideshow. This is on our website, so we will sit back and just listen as you enjoy Let Me Do. Let me
questions for us, for the Chinese? I was in that session when we asked the stroke survivors what they wanted to know, what they wanted people to know. So I was actually leading that group, and what's interesting about the song is I had a music therapy student with me that weekend, and there was a nurse in that group. And the next morning, the music therapy student got up really early, and the nurse actually had this melody in her mind. She woke up with it. She was not a musician. And my student was there sitting at the piano, and they pretty much came up with this basic song. And then I sort of ran with it, and she kind of put it all together, and then we adapted it for the Chinese. So we just never know what comes out of camp. We know it all. And music is very powerful, as you know. And in a therapeutic situation, we write songs so that patients and clients can express themselves through music. And it's easier through music sometimes than just words. Our last song is going to be Battle Hymn of the Republicans, so we invite you to sing with that. This is Pat's favorite song, isn't it, Pat? She's always wanting us to do this. And for this one, we'll use the chart. Any questions that you have for any of us before we close out today?
Are you ever recruiting new members?
Yeah.
Our goal is to have all stroke survivors, but we don't have enough who are willing or able, because when we have new members, we do tell them that we perform. So it's a commitment to practice once a week as well as to perform. And not everyone can or wants to do that. So we recruit our caregivers, and then there are also our fill-ins. Yes. Any other questions? Any questions for the survivors? Okay, awesome. You had seen a video of our first year compared to this year. Talk about improvement. And one of the biggest, I think, therapeutic benefits is attention. As you know, or as you can see, they have to have their eyes on us 100% of the time, or else they'll miss their cue. And so this is helping them not be so distracted in a new setting. Every time we go into a new setting, that's somewhat difficult, for them, different than a practice room for that. So their attention, their motor planning, and their ability to play has just increased 500% every year. We'll close out with Battle Hymn of the Republic. My eyes have seen the glory of the coming of the Lord. He has trampled out the vintage red, the grapes of wrath are stored. He has loosed the fateful lightning of his terrible swift sword.
Bob's speech, because after his stroke, he could not speak. And when we saw the chimes the first time we were at camp, and he said to me, "I would like to do that." I said, "Okay." So I called Mary Lee, and it started, and over this, what has it been, 4 years, 5, I don't know. 4 years, his speech has just improved 100%. And I attribute it to this because he wasn't doing any speech therapy anymore. And this has just brought it out of him. So I just wanted you all to know the importance of music. And the social life. I mean, we get to go out. I mean, my gosh, you know, we socialize and we go out to eat before we practice every Tuesday night.
And you get a chance to clean up every once in a while.
That's right. Yes, it is. Yes, it is. So, anyway, just wanted y'all to know that.
Thank you all very much.
Thank you.
Right now, the one I she lives there in Baltimore. Thursday, Friday, Saturday, Sunday, Monday, Tuesday, which is off for 2 minutes. But she's still
International Stroke Conference. I don't know how many of you guys went to that, but really what the big breaking news was the intervention piece. IMS 3 is essentially gone out of the window. There's, Mr. Clean 4 trials that proved, if you will, that now the standard of care is occupations intervention in summary. And this has been, it's new, one, and it's been very difficult to disseminate that information to referring facilities, to EMS providers, to understand why we're expediting patients to hospitals that provide interventional services. So I wanted to share, kind of paint this picture, because that's been one of the things that I continue to hear echoed across, when I travel, all these institutions that I go to, is what does a possible intervention patient smell like? We know what a stroke, TPA patient smells like. Now paint the picture of a interventional candidate. And don't stop the time. That is, we often, when we get TPA, we're like, okay, let's go ahead and admit. That time is not stopped. It has to continue on to get further diagnostic tests, communicate with an interventionalist to see if they're going to be a candidate for intervention. And so that really changing the mindset, we did a nice job, emergently and efficiently putting somebody through till TPA, but now we have to emergently and efficiently work a patient through the continuum until intervention.
Just started over.
Yeah, and so we're just kind of starting over. We really are. You're kind of going back and saying, okay, now we need to continue to press on. And it's also education from an EMS provider standpoint, and that's where I've focused a lot on lately, is reaching out to EMS rigs. We have 40 different rigs that transfer to us, or companies, but and try and understand, where the gap is. They don't, as to, if a patient is outside of the TPA window, now the legislation allows bypassing hospitals. And so there's no reason that a patient should be going and stopping at an acute stroke ready hospital or even a primary hospital if they cannot provide endovascular treatment outside of the 4.5 window, 4.5 last one window, because they're not going to be able to do anything. So if you have a large smelling stroke, then the best thing for the patient is to go to a center that can provide services for the patient. I mean, that's the whole goal. So, and that's a completely new world for a lot of people. And it's not, it's only between 4.5 to 8 hours is really what the literature is at. So educating as to why we're doing this, why we're supporting this. I don't know how many different regions we have in here, at least 4 different regions, EMS regions. We all have different protocols, but they're essentially saying the same thing for the most part. Some of you guys may not even know. Do you even know what your EMS transfer protocol looks like? You've seen it? Have you seen it? Okay. If you haven't, reach out to your EMS coordinator or whoever your referring facility is, because you need to know what that looks like. That's imperative because it's going to impact you guys, every hospital. It's going to impact every hospital. But anyway, I just wanted to share, and I'm willing to email this out. This This is essentially a protocol that we created to paint the picture for referring facilities. It's not all-inclusive. It can't be all-inclusive because there really is not a standardized paint pick, you know, as if the TPA inclusion-exclusion criteria, we're not there yet. There's no guidelines out there yet for intervention. They're working on it, but there's still, it's going to be a little while, as we all know how fast that process works. But really what we're trying to do is make sure that EDs in referring areas know that this possibly could be one. So I just wanted to kind of start the discussion. So thoughts, questions in regards to how this impacts you guys, any concerns with it? Are you guys hearing any pushback? Is there any need for education in these certain areas? Yeah.
I'm still hearing a little confusion about how long, what the window is for the endovascular.
Well, posterior is a longer window. You're up to about 24 hours if you're talking about basilar clots and things, because the mortality of those populations is incredibly high. So we give them the benefit of the doubt. And usually it's an area that it doesn't infarct as quickly either. So you have a number that's salvageable, and if you don't save it, the patient's going to die regardless. So that's the window that's pushed a little bit longer. From all the trials, last 6 to 8 hours, up to 10 hours. I think the escape was up to 10 hours, but typically between 6 and 8 hours is the time of last known well. So you have 8 hours from the last known well to go in there and have the interventionalist mechanically remove that clot. So a lot of, this may impact some people's stroke codes. We're actually looking at ours because ours right now is last known well of 6 hours. And we're talking about expanding that to 8 hours. So if you're activating your stroke code within your ED, if it is, say, within 3 hours of last known well, we need to start modifying that, because you need to start working up patients with a last known well at least for 6 hours, especially if you're transferring, so there are lots for transfer time and things like that.
I think it goes back to the same thing with TPA. If you most of the time can look at those patients and know this is a pretty severe stroke or a large vessel stroke, especially if they've got a lot of cortical signs, gaze deviation, aphasia, weakness, those types of things. And so the bottom line of it is we got to start thinking every patient may benefit from this. And so let's call, find out, get with whoever to see what do we need to do. Because the actual studies showed they selected these patients by doing CT angios. So it may come to the fact that while you're waiting for transport, if your hospital is able to do a CT angio, then we may be having you guys do that before they send to a comprehensive center. So it is going to change the way things happen. So it means that we're going to have to be really, really quick and emergent in thinking, way past IV TPA. So like I said, it's kind of the same kind of swing. We're kind of going backwards though. We're starting all over. We're doing a really good job with TPA, but now we have to really push the envelope for those interventional candidates. So, and I think
all of basic patients, I don't know if you guys include anybody that has aphasia. If that's your only symptom, we look at that patient as a possible intervention candidate. And then NIH stroke scale of 8 or greater is usually that point of, okay, well, this could be a possible intervention patient.
The thing of it is if it's not, great, but work them up. We need to at least start thinking and working them up and start planning for transfers. Especially after seeing the stroke survivors and stuff, we owe it to these people to give them the very best and most comprehensive care that they can get. And we know that not all centers can do it, and that's great. So let's make sure that the appropriate patients are coming to the appropriate hospitals. If you can give TPA, get the CTA, and ship them on, but we just got to make sure that we're getting that done as upfront as possible, so we're not wasting any time. So that's kind of I think our goal is, from this group, is to just get our process in place so that that's happening.
120 minutes or
Yeah,
so.
so it was really fast to, to show that benefit, so, and we all know time is brain, so, not only, the TPA doesn't work all the time, and sometimes it only works, for a short time, it doesn't always dissolve that whole pot, so it's just something that, that's our next big push now, is to try to get people to start thinking well past the TPA.
Yeah, I was thinking the study showed after 6 hours, there was decreased benefit, but still some up to the 8 to
Yeah.
10. But
It's
6
just
is
not as
kind of
much,
okay.
yeah.
Is that correct? Yeah.
Correct. I think, well, there's 4 different trials, and Mr. Clean, I think, cut off at 6. Escape, I think, was the one that went up to 10, or 8 or 10, yeah. So there's not a standard. And it's really, the reason that there's not a standard is because, if you have collaterals and things like that, there's still a lot of, if you have a lot of penumbra, it really doesn't matter. If you don't have a large infarct and there's a lot of penumbra and salvageable tissue there, they're going to go after it, regardless of lasting well, because that usually means they have collaterals or some other kind of mechanism that their brain is still perfusing, but yet if you don't do anything, then you are going to have a large infarct. And so that's why we do perfusion scans. You guys do perfusion scans to see a mismatch, because then it can give the interventionalist if there's no penumbra, if there's no salvageable tissue, regardless. We just had a patient, I don't know, a couple of weeks ago at this time, that they were lasting well, like within 3 hours. They TPA'd a patient and took him to CT, got a CT, and it was already gone. And so there's no reason to take that patient to intervention, regardless of lasting well, because there's no penumbra. So we're not going to take a patient up and try and open up a vessel and cause more harm than good. Is there facilities, can every facility do a CTA? No, there's some that aren't. And so that's been another thing, is to, how do we, from a transfer center or a neurologist or whomever's that first point of contact, how do you communicate that back to the facility? Is what's your capability? If you can do a CTA, do a CTA. Because then if there's not a clot there, then you can essentially say, then this isn't an intervention candidate. But if you cannot do a CTA, if you're just doing a plain head, you're looking for like MCA signs and things like that. But that's really where you want to push the envelope, because you don't have the ability to read those out.
My question is, what do we do with physician education? Because this is all nursing, and I can go educate my nurses if my physician can keep an eye on them.
So,
Well, actually, Sarah Stade was supposed to be here. There are people within the interventional communities. Stryker is one of the makers of one of the flat retrievers, and then there's Medtronics. They actually have people that's their job, is to come out to hospitals. And Sarah was actually supposed to be here today, and I don't know what happened to her, but they want to know how they can help. They want to be able to go out there and educate and provide you with whatever it is that you need to educate your physicians or your staff or whatever. So
we've been going out with our interventionalists too, and just sending them to all the possible locations to say, give me your med staff, give me your, it's ED staff typically, give me your ED department meeting, and let me at least give you an overview of the trials and say this is kind of why, things are leaning that way.
So are they reaching out to beyond facilities doing intervention too, is what you're saying?
Yeah.
Yes, Stryker's been really good.
I didn't bring the flyers, but we're doing a couple of dinners in conjunction with them. We're doing one in Peoria on May 11th.
May 11th.
Yeah.
Yep.
And that's going to be on the acute endovascular changes, all the acute changes in stroke. And then we're doing one up in the I-80 area, May 12th, at the Uptown Grill. So if any of you are from up that area and you want to come, it's free dinner. It's for physicians, nurses, EMS, anybody. So it says physician dinner, but that's only because physicians are giving the talk. So it's for everybody. So if you can get strategic members of your team together, it would be a great opportunity to have a really nice free meal and to learn.
So where's that located at?
Actually, it's located in our computer.
Okay, send it to our contact. I don't know that they're sharing it out with others.
Yeah.
So I'm so sorry. I know people have emailed me left and right. We really having issues. So if you're not getting emails, please let me know. I've created my own distribution list because, yeah, I just can't get it to work. So, sorry. What did you say?
Tim, I don't know if it would be appropriate, but would you be willing to share that, you did that nice summary of all the different trials, the endovascular, that you shared at your regional stroke meeting? Meeting? I thought that was like a really good, like, at a glance.
Okay.
Is it like a one-page summary? I know Stryker has a really nice PowerPoint. I don't know if that's what you're using, the breakdown, one page, one-page table that has a breakdown of it. And I might try and get Stryker's presentation and send it out via the listener as well.
And I'll get, yeah, I think Dr. Nair did it, but we can send that out. We can also, feel free to email me. I'll try to send out Sarah's email as well, so that you can contact her, so that if you do have education that you want to, do, that she'll come up and help with that. Or if you want a dinner in your area, they're more than willing to set that up, get the place, provide all the stuff. All you got to do is get the people there. So it would be a really great opportunity to have a night out with a good dinner and good talk about stroke care. So
Meg Armington is the one with Medtronic who will come and do education.
yeah, she'll do education to your staff. So there's lots of resources out there. You guys don't have to do it alone, and you don't have to be the one to do it. They've got the information and the money to make it happen. So we need to tap into those resources as best we can. So.
Any other questions on endovascular? I didn't want to beat it through the head, Yeah, but I did want to at least touch on it because I know it's kind of a struggling point for many institutions. Okay, how much time we have before that?
We got about 15 minutes.
15 minutes. Well, let's just have a group discussion about what, instead of breaking, I know we usually break up into groups and split them up. I think the most important one is community education. For the reason of Peggy is applying for another grant for ICANN and is willing to give Stroke Inc. some funding if we come up with a collaborative community education idea. So.
She had a few ideas too. She
oh yeah, I put a couple up there.
Yeah, she talked about if we wanted to continue the fifth grade education, or if we wanted to do some of these other things, as far as like a dinner or something with the churches, the barbershop thing. I mean, anything that we want to do to try to educate our communities more. She's really willing to help us with some money.
We just have to show the engagement. I mean, that has to be on us. If she's willing to give us money and write the grants and those kind of things, we just have to be committed to doing something and to reduce some of the variation of what we're doing. Let's find a unified idea, like fifth grade education. Great, fantastic, continue it. This is going to be kind of a second initiative.
Some of the smaller communities won't have the opportunity to impact the African American community because, so I don't think that that's something that we can say everybody can do that. But what would, could we all have nursing homes and, group homes, people like that, and maybe we could go there and teach them to watch out for one another.
Right.
One of the women that was in the group, she said that her stroke symptoms were so odd, she thought she was talking perfectly fine. She thought she made sense. So when her daughter got there, she was aware that something was wrong. So, those folks in the nursing homes perhaps would be interested in knowing how to look out for one another.
Well, I think staff in nursing homes too. They need
Staff. I do a lot of LPN education, and that's who staffs,
Yes.
who staffs nursing homes. the only thing that they get in their whole education is because I go there for an hour and speak to them about stroke. I mean,
We've
that
got
is,
that's it, stuff
that's it.
out in nursing homes now. Where,
Maybe there's an opportunity there.
Yeah,
And could that be professional? That could be a professional too.
yeah, that's true. So, keep two birds with one stone.
I've had a couple of patients that have come into the ED, just in the last month from nursing homes, and there was no last known normal, no last known well. You know, I know we're busy, but, I planned on going out after our joint commission recertification and starting to talk to the CNAs and the nurses just about how important it is to let the EMS know that when they.
yeah, I think it's a huge opportunity for us. I think it's like Amanda says, it's much needed. They don't always get a lot of the opportunities for education that, you know, RNs get. You know, I think nursing homes, there's a lot of people that are in nursing homes for one reason or another. I even like group homes. My mom, she lives in an independent apartment building, you know, and these people watch out for each other. And I was like, you know, that would even be a really good place to, you know, just places like that where there's a group of people, they have a community room, you know, you bring some cookies and some coffee in and they think they're in heaven, you know. So, you know, just to get that out to what to watch for, you know, when they're with people. So I think we've got some really good opportunities. I would really, really strongly encourage you that if you did do the stroke education, if you could get us a list from the teachers of all the kids that were in the class, anything, so that we can show the impact that we made, so that we can help support this grant from Peggy, because we're doing this work, you guys we just need to get credit for it. We need to show the impact that we've had. So, and we can't, data talks, everybody wants data. So, you know, whatever you've done, you know, bring that to us, get it, even if it's just a list of how many schools you did or how many kids you did, so that we can actually show, you know, put some meat behind it, so we can get that.
Speaking of data, have you guys seen this? So I've sent out a couple of emails begging you guys to send your TPA numbers to Tyler Dansky, who is the incoming president for Association Stroke Coordinators in St. Louis. What he's done is compiled all of these percentages of hospitals. You can see how many Illinois hospitals participated. But I think there's a big opportunity here. And so what they're doing is identifying areas that are obviously doing things really well and understand some of their best practices, and then areas that could, you know, use some improvement, and then creating initiatives around, you know, how do we go after these hospitals? What are they doing well? What are we doing not well? How can we improve? But there's been a lot of transparency. So as you can see, none of your hospital's information, you know, the name is not going to be disclosed. And I can send out the spreadsheet again. But I would really encourage you to get some more Illinois participation so we can see how people are doing all throughout the state and kind of identify areas that we could improve on. Sorry, I didn't forget about that. Questions with that?
Amanda, there's supposed to be someone at the Department of Health in Chicago. She called me to ask me all kinds of questions about how we implemented stroke in Illinois. And she's supposed to be doing her research or something. She's a fellow from
get it, I get it.
Too,
This
and it's
was,
like, they asked for a whole bunch of different things that I had to go back and look up and.
yeah, well, and, yeah, I agree, I agree. This is, the numerator and denominators are from GIPSy guidelines, I think.
And this is TPA.
Mhm. Yeah. And really what they're also doing is trending it out and to see, differences between 13, 14, and 15 to see are things improving, are we doing better, are we doing worse, where do we need to focus on? So I'd encourage you to send your information down just so we can kind of get some more Illinois stuff going. Okay, that's all. I just didn't want to forget about that. Okay, back to community education. So I kind of do want to respond back to Peggy. Is everybody liking the idea of nursing home education? I think we could probably come up with a similar template that we did with fifth grade education. So there's a curricula, so it's standardized, to who we're presenting to, whether it be the LPN staff versus the resident, or wait, they're not called residents, they're called residents. Aren't they? Yeah, residents. So that way we can all, so it's here you go do it kind of thing. The one I gave in Shelbyville for their girls' night out, I think would be very easy to give. And it was, you could condense it down to be 15 minutes. And then we can, outcomes, how do you measure outcomes with that? Just number of residents? I guess, facilities, number of residents, staff? All right. You guys don't seem enthused about it. Anybody got any better ideas? I know it's not as fun as fifth grade education, but.
Well, I personally like the idea of the sporting event.
The sporting event.
Yeah.
Yeah, we need to talk about that.
Yeah.
That guy left, didn't he?
Oh, Galia.
Or no, the other guy.
EMS
guy.
Bradley.
Yeah. Yeah, that would be very cool. And it'd be very easy to do, especially if you work with your EMS coordinators or whoever.
So maybe we could do the nursing homes, we could do that for professional education and at least to get the staff out there to know things to look for and maybe even some of those things that they're seeing, especially if they see somebody with a gauge deviation and, things like that, to know that, this patient is going to may need something more and it's a long time window and, that they need to move quickly. And then perhaps for the community, I think the sporting event is a really good idea because like she said, everybody has a high school football team or, something, basketball, whatever, wrestling. I mean, it can be anything. Yeah, track.
So, just outcomes on that. Curiosity kills the cat. And so I took 3 years of data from EMS versus walk-in. Because our goal, right, is to get people to call 911, and come in by EMS. So I pulled, I don't know why, I just thought it would be interesting, 3 years of walk-in versus, EMS. And then I went back and filled in every community education event I did. And I wouldn't think this, it blew my mind, and I need to bring it here for you guys. There's a spike after every single one of my community education that people are calling 911, that our patients are coming in by EMS. So there was complete direct correlation with that. Now visually, I'd have to calculate as to statistically how much, but there was indeed a spike after every community education I did. So to me, it's like saying, okay, that's why we do this. That's why we do this. There is some outcomes to this, and it actually shows in some of the data. So
we see the same thing because like when we do our stroke month in May, we usually see a huge spike in July and August of patients coming in via EMS.
It's like May is like 70-30, EMS versus walk-in, and then it'll go back down, 60-40, and then October around World Stroke Day, it'll peak back up, and it'll be, 80-20, and then, so.
And it does, I think it does
How do
make
you
a
sustain
difference, the seasons of the year too, because people tend to call 911 in the wintertime more often than they do in the summer because they don't want to get out on the roads or whatever, but.
Ours always goes up in February. I don't know if it's due to all the heart, that all the education happened in February. Yeah, our 3 years in a row, our spike's up in February.
So, I guess from, you know, we need to kind of, since Peggy's writing this grant, especially for the community, I think we kind of need to take a vote to see how many of you think the sporting event idea is doable and something that we can look at as far as figuring out. Does that seem like something that everybody would be able to accomplish? I think so. I mean, that was kind of like the 5th grade education, you know, you got to at least have a 5th grade class somewhere. So let's not make it harder on ourselves and, you know, tap into, you know, what we can use. So
But we can also tie in the fast and sports.
absolutely.
Yeah.
I mean, there's a big possibility of how you can, you know.
People as the day goes on, so it's not you, it's me. I'm sure they got tired of me. Here's the clicker, and I don't know if you want to just give a little bit of overview as to who you are and what, yeah, and then. Yes. Does that work? We're good? Okay.
All right, good. Well, thank you all for inviting me to come and talk to you. My name is Angela Brown, and I'm an associate professor of medicine at Washington University down in St. Louis. And I actually direct the Resistant Hypertension Clinic. It's a clinic we started about 14 years ago. And it's really to treat patients who have high blood pressure that's very difficult to treat. And when I was driving up, I passed the Springfield Clinic, and I saw St. John's and Memorial. I was like, oh, these places sound familiar. Because believe it or not, I actually get patients who live in this area who come down to St. Louis. And a friend of mine rode up with me, and I was like, you know, they tell me they come to St. Louis because it's closer than going to Chicago, for care. So I do have quite a few patients who live in this area. But with our clinic, we see patients who you're concerned about having a secondary cause of hypertension, or they're on multiple medicines, they're not controlled, and you just don't know what to do next with their medical regimen. So we're always taking new patients. I'll put a plug in for our clinic, and happy to see the patients for hypertension. And the other thing I do is I do research as well. I've been an investigator with the Diabetes Prevention Program which is an NIH study, which looked at lifestyle and metformin with prevention of diabetes, and I've been involved with that program for about 15 years. And we're getting ready to roll into another 5-year observational cycle with that. So teaching, research, and taking care of patients, that's what I do. Can you guys hear me in the back okay? Okay. So what we're going to talk about today is the treatment of hypertension, and particularly address racial and ethnic disparities related to hypertension. My name. And these are my disclosures, which I have to tell you, I think. I am a part of the Speakers Bureau for Arbor Pharmaceuticals and consultant for Lundbeck Pharmaceuticals. I'm not going to talk about anything that's unapproved, or if I do, I will tell you it's unapproved. And I have research support from the NIH as well. So those are my disclosures. All right. Okay, so we'll start with a basic patient profile. And the question is, are you aware of the risk factors that our patients have? And what I like to say is that a lot of times, even though someone comes in the door because they have hypertension, risk factors travel together. Obesity, diabetes, hypertension. They're just one little group, and if they have high blood pressure, there's a high likelihood they may have one of the others as well, including hypercholesterolemia. So this is a 42-year-old African-American man, has a daily routine that includes adequate exercise. Now, this says adequate exercise. When patients tell me I exercise, my question is, what does that mean? It's just like I drink. Okay, what does that mean? You drink what? I drink alcohol. How much? So what does adequate exercise mean? And we'll talk about that a little bit more as to what the recommendations recommend for adequate exercise. But try to quantitate, some of these things when you talk to patients, because for them, adequate exercise may be, because of my job, I have to get up from my desk and walk to my boss's office 15 times a day. Well, that's not really adequate exercise because you're not keeping your heart rate up. Or they tell me I walk every day, and I see some of these people walking, and they're just kind of loafing along, taking their time. So just make sure you're on the same page with the patient. Anyway, his current readings, he has a body mass index of 25, which is okay, waist circumference of 34 inches, fasting glucose of 101, which is right there at the cutoff, total cholesterol of 189, and a blood pressure of 148 over 92. So how aggressively would you treat hypertension in this patient? And how would race and ethnicity affect your treatment decisions? So that's kind of what we're going to talk about as we go through this. But any thoughts about how aggressively you would be if someone came in at 148 over 92? Would you leave them alone? Would you make a change? Would you still address something with them? Or
Yeah, he needs to be treated.
he needs to be treated, right? He needs to be treated a little more aggressively because based on the guidelines, the target should be less than 140 over 90. And patients are going to give you all kinds of excuses. My blood pressure is a little bit higher today because traffic was horrible. I couldn't find a parking spot, or I got in a fight with my wife. And so if they give me that excuse and I see this blood pressure, then the next thing I say is, okay, well, let's have you monitor at home and send me some readings. Because I want to make sure that this isn't where you're living all the time. Because there's a high likelihood that this is probably where the blood pressure is most of the time. So the disparity disadvantage, who is at greatest risk for gaps in treatment? So what we know is that despite having multiple medications, we have over 125 antihypertensive medications that basically fall into 9 classes. The majority of our antihypertensive medicines now are generic. We have very few medicines for hypertension that are not generic. There are a couple of the angiotensin receptor blocking agents, the direct renin inhibitor, that are still name brand, but all of the others are actually generic. So despite the cost being low, and despite our medications being very effective for treatment, we know that black men and women are more likely to die from heart disease and the complications related to hypertension, like stroke, than whites. CHD and stroke are the largest determinant in inequality of life expectancy between blacks and whites. So what are some of the markers that we can target to close these gaps? And clearly we're going to talk about hypertension because that's a big one. And what we know, and this data has been fairly consistent through the American Heart Association for about the last 8 years, is that blacks and whites, blacks compared to whites, the death rate directly related to hypertension is about 3 times greater in blacks than it is in whites. And that's from looking at all autopsy records and death certificates. So I will throw in as well my other hat that I wear, and that's why my scarf. I'm actually the president of the local American Heart Association board in St. Louis, and so this is the most recent Go Red for Women scarf, Life is Why. So I'll throw that plug in there. So if you're online, you're looking for a pretty scarf, it says Life is Why, my family is why, and so forth. So anyway, back to the topic. Sorry about that. 1 in 3 U.S. adults has high blood pressure. 82% of those with hypertension are aware that they have it. So that means that there's 18% that don't even know they have high blood pressure. Because remember, for the longest, the campaigns were that hypertension is the silent killer. And it's still a silent killer. The majority of patients do not have symptoms related to their high blood pressure. About 75% are being treated, but of those being treated, only 53% have their blood pressure controlled. That means that their blood pressure is consistently less than 140 over 90. Now, the JNC7 guidelines say that goal blood pressure should be less than 140 over 90 for most patients, but for chronic kidney disease or diabetes, less than 130 over 80. How many of you are familiar with the new JNC8 guideline? So JNC8 actually came out at the beginning of 2014, and somewhat controversial guidelines, because what they actually say is that still for most patients, blood pressure should be less than 140 over 90. But that recommendation changed for those with diabetes or chronic kidney disease, and instead of the lower target of less than 130 over 80, they actually recommend now less than 140 over 90 for that group as well. And I think the most controversial change is that when they looked at the data, they actually recommended for any individual over the age of 60, the target should be less than 150 over 90. So actually raise the target. So not long after that recommendation came out, a subset group of that panel published a paper that said they did not agree with the less than 150 over 90 for those over the age of 60. And their biggest concern was because of the risk of stroke. So those guidelines are actually very controversial, and most of us are still going by the JNC 7 guidelines. And so what we'll have in 2016, another panel has been convened to sort of relook at the data to give us another set of guidelines to make sure we're in the right pace. What do I do in my practice? The majority of my patients I treat to less than 140 over 90, whether they're under the age of 60 or over the age of 60, because you have a lot of 60-year-olds, 70-year-olds who are very healthy, high blood pressure is their only issue, they're active, the whole 9 yards. Why would I want to let their blood pressure run higher? But I will say, as patients get older, you do have to individualize therapy a little bit more so that you're not, because a lot of patients get dizzy. You know, you have 80-year-olds, they take their blood pressure medicines, they're dizzy. So maybe they don't tolerate 140 over 90. They may feel better at 145. So you really do have to individualize therapy. All right, so some unique markers of hypertension in African Americans. It tends to come on earlier in life, so premature onset. We see an increased incidence of target organ damage because of that. Left ventricular hypertrophy, so thickening of the main pumping chamber of the heart. Heart failure, impaired renal function, chronic kidney disease, and end-stage renal disease. And if any of you have ever been in a dialysis unit, even though blacks make up about 13% of the U.S. population, you walk into a dialysis unit, about 80% of the people that you see in a unit are going to be black patients. So the overwhelming disparity in numbers there is really significant. Blacks tend to present with an average blood pressure that's much higher when compared to whites. So at the time of presentation, you have blood pressure that comes on earlier in life, but it's also higher. It also tends to be more difficult to treat, therefore we have these complications. And the prevalence of high blood pressure in African Americans is among some of the highest in the world, about 44%. And this slide actually shows the, again, this is the hypertension age-adjusted death rate. And this is what I alluded to earlier, that for blacks, it's right at, a little over 40%, whereas if you look at other groups, they're under 20%, okay? So compared to Asians that are about 14%, that's almost a threefold difference. So the death rate definitely disparity. This slide actually shows hypertension awareness, treatment, and control. And what you see here is that awareness in whites is at about 82%, in blacks about 85%. So we've done a fairly good job of making people aware of hypertension and getting screened. It's still lower in Mexican Americans. So we're lagging behind in our Mexican American patients, not only in awareness and treatment and control as well. But when we get to treatment, you see blacks and whites are about the same, but the control rates in blacks is still lower than that compared to whites. And clearly Mexican Americans are much lower than both groups together. So this is just a summary. Blacks tend to have greater awareness and nearly the same treatments as whites, but as with Mexican Americans, the control rates are actually less. This slide again just reiterates the prevalence, breaking down men and women, blacks and whites. And what you see here is that black women, or non-Hispanic black women, actually have some of the highest prevalence for hypertension. So some data has shown that if you are over the age of 70 and you're a black woman, you have about an 85% chance of having high blood pressure. So very, very significant. And this disparity exists among children as well. This just shows adolescents ages 12 to 14 between boys and girls, blacks and whites. And what you see here is that black boys tend to have a higher incidence of high blood pressure compared to whites and Mexican Americans. And black girls are here. So black girls catch up as they get older and go on through life. And this is really important, I think, for all groups, because I would actually say I'm seeing more patients in my clinic who are transitioning from the pediatric hypertension clinic to adult hypertension with hypertension that needs to be treated. And part of that is because our children are more obese than they used to be, and they're not as active as well, and their diets are horrible. And the Heart Association has some great data looking at these markers in children, and we have a lot to do when it comes to physical activity and diet for our children. And it's really important because clearly if our kids are starting out younger with hypertension, diabetes, obesity, cholesterol issues, that means they're going to have negative outcomes earlier in life as they tend to get older. All right, so what are some of the costs and consequences related to poorly controlled hypertension? Basically, if you have high blood pressure that's not controlled, all of the vascular beds, all of the organs that are vascular can be damaged. So clearly an increased risk of TIA and stroke and dementia. So a lot of patients who may present to the emergency department with a first stroke or a first TIA, you get a head CT, you may see the acute stroke, but often what you see is small vascular disease as well. Changes that have occurred in the brain over time as a result of uncontrolled hypertension that has not resulted in frank physical disability type symptoms. You know, as we talk about the weakness, the numbness, the facial droop, that kind of thing. But those changes are starting to occur there. And one of the things we do see that's often unrecognized is dementia. So a little bit of confusion, memory loss, and so forth related to uncontrolled hypertension. And then clearly retinopathy, changes in vision, peripheral arterial disease, chronic kidney disease, as I mentioned, and then also changes to the heart. Left ventricular hypertrophy, coronary heart disease, heart failure, and angina. Complications, we'll just kind of run through these a little bit. And for all of these slides that I'm going to show you, what you're basically going to see is that the complication prevalence for blacks is greater than the other groups, whites and Mexican Americans. So this is the data for heart failure. You see black men here in red, black women in kind of the pinkish color. If you look at complications related to stroke, women, okay, women greater than men. Now part of that has to do with the fact that the life expectancy for African American women tends to be a little bit longer than African American men. They're living longer, so age itself, whether you have hypertension or not, puts you at risk of having a stroke. So when you're older and you have hypertension and that high blood pressure is not controlled, then you're going to see clearly this disparity in stroke prevalence. This shows the reduction in stroke rates in the U.S. Among African Americans, Hispanics, Asian Pacific Islanders, and whites. And again, what you see here is that although all of the groups have had a decline in their prevalence, African Americans are still lagging behind. So the difference here, when this, from the 1990s compared to 2006, when this was reported, this was 2014 stroke update, the data lags behind from reporting, is that even though this gap is a little bit narrower here, it's still pretty significant when you compare it to the other groups where the gap between groups is narrowed significantly. So we're still lagging behind in the reduction of stroke rates. Coronary heart disease, here white men actually do have a greater prevalence, but still very significant in black men and women. This shows the death rates. Death rates are actually higher. Okay, so the prevalence, just a little bit lower, but the death rates in African American men are higher. And this is a slide that I mentioned, again, mortality from high blood pressure in blacks compared to whites being almost threefold difference. So significant gaps in our outcomes in these groups. Complications related to kidney disease, the same things. This is the rate per million population, and you see blacks, African Americans way up here compared to other groups here. And these are all complications related to hypertension, heart disease, death rates, blacks here, the red lines on top, other groups here at the bottom. Below that, again, a significant difference just based in the racial disparity. Okay. So let's just talk a little bit about hypertension itself. What's the difference between primary, secondary, and resistant hypertension? The majority of cases of hypertension fall under primary hypertension. It used to be called essential hypertension. And it was called essential hypertension because it was thought, what they saw epidemiologically was that as people get older, the blood pressure tends to go up a little bit. So it was thought that it was essential that you have high blood pressure to perfuse the brain. And I remember when I was in medical school, we were taught that the systolic blood pressure should be 100 plus the age So if you were 70 years old, it was okay to have a blood pressure of 170 because it was essential that you have that 170 to perfuse the brain. So that if you dropped it below that, you wouldn't get enough blood flow to the brain and grandma and grandpa would walk around confused. And if you go back and look at the J&C guidelines, the first two sets of guidelines did not have recommendations for systolic blood pressure. It was purely just based on the diastolic blood pressure. With J&C 3, there was a recommendation for systolic blood pressure, but the cutoff was 160, not 140. So it wasn't until we had the hypertension in the elderly program trial and the CIST-UR trial that actually showed us that for elderly individuals, treating the blood pressure down, for sure below 150, and in those trials, blood pressure got down to about 144, that there was a significant reduction in stroke when you lowered the blood pressure. So that's where that term essential kind of came from. But primary hypertension, 95%, it's treatable, but we can't identify the specific cause for it. Hypertension is multifactorial. Lifestyle, genetics, obesity, age, a lot of things play a role there, so we can't pinpoint one specific thing that contributes to primary hypertension. Unlike secondary hypertension, which is probably about 5%, I would even say more so 2 to 3%, really. But secondary hypertension, you can identify a specific problem, treat that problem, and the blood pressure becomes controlled or goes away. So chronic kidney disease, aortic coarctation, which is often picked up more commonly in the pediatric population, although every once in a while we'll see an adult with aortic coarctation, where you have a narrowing of the aorta. Cushing syndrome or other glucocorticoid excess states, drug-induced hypertension, so cocaine, a lot of the medicines that have been pulled for weight loss, they would cause sudden increases in hypertension. Sudafed is another one that can raise blood pressure. Some of the medications that we prescribe for patients, so erythropoietin for our patients with chronic kidney disease, birth control pills. Birth control pills aren't as much of an issue as they used to be because the estrogen levels are much lower. But when birth control pills first came out and the estrogen levels were much higher, we saw much more hypertension related to the use of estrogen-based therapy. Obstructive uropathy, pheochromocytoma, the tumor of the adrenal gland that overproduces adrenaline. Primary aldosteronism, overproduction of the hormone aldosterone. Renal vascular hypertension, so narrowing of the arteries to the kidneys. And this is actually in two forms. As people get older, they're more prone to cholesterol-type plaques in the renal arteries, just like you get in the coronary arteries. But in young people, 18 to 30, young women, hypertension, sudden onset, no family history, there's something called fibromuscular dysplasia, which is a thickening of the wall of the artery itself, which causes a narrowing of the artery. And treatment of that with the balloon angioplasty is curative. And actually, I have one of my patients that I follow from Springfield actually has fibromuscular dysplasia. I've probably been seeing her for about 10 years. Sleep apnea. Sleep apnea is something that patients don't walk into your office and say, I have sleep apnea. You have to get that from the history. The person that snores, usually it's the spouse that's with them and says, they snore like crazy, I have to sleep in another room. And the patient actually says, really? I didn't realize this. I don't hear myself snoring. No, you're not going to hear yourself snoring. Some people do say they're snoring wakes them up, but most people don't realize they snore. But what they complain about is daytime fatigue and just kind of general poor sleep. That no matter how much sleep they get at night, whether it's 4 hours or 10 hours, they're never rested. But treating sleep apnea actually helps get the blood pressure controlled. And also, and then thyroid disease and parathyroid disease as well. So those are the most common secondary causes of hypertension. Actually, I'll also add to that sodium intake. There's a lot in the literature about, what about salt? What about salt? But for someone who has hypertension, who's on medication, who consumes a very high sodium diet, you see blood pressure a little bit higher. Because with the high sodium, excess sodium does, it actually interferes with the antihypertensive therapy, particularly if they're on a diuretic. It makes that diuretic less effective. and calcium channel antagonists as well, like Procardia, Norvasc, or amlodipine. So I would put sodium excess on this list as well. Now, what's resistant hypertension? So resistant hypertension is blood pressure that's not controlled despite the patient being on 3 or more blood pressure medications, preferably one of those being a diuretic, or they're on 4 medications and they're controlled. Okay? So that's resistant hypertension. And it's thought to occur in about 1 out of 10 hypertensive adult patients. And these are the patients that we primarily see in our clinic. The folks that have seen their primary cardiologist and they just kind of don't know what to do next, so they send them to us and we work on them. Some associated patient characteristics with resistant hypertension tend to be a little bit older, higher baseline blood pressures, obesity, this excessive dietary sodium, salt in the diet. Chronic kidney disease is a big one because as the kidneys start to fail, blood pressure starts to get more difficult to control. Diabetic patients, black patients, female, and then patients who live in the southeast United States. Used to be called stroke belt across Alabama, South Carolina, and Georgia. Some of the highest rates of hypertension, but also some of the highest rates of stroke as well. How do lifestyle factors contribute to resistant hypertension? Well, obese patients when the BMI is greater than 30, consuming more than 1,500 milligrams of sodium a day. Now, when I talk to patients about sodium, I basically tell them don't even try to count it because there's sodium in everything. I mean, if you even look at, the soda that you had for lunch today, there are a few sodas that don't have sodium, but there's sodium, in everything. So we try to educate them about how to avoid sodium. And that means really getting used to looking at labels. And if it says more than 300 milligrams per serving, then try to avoid that. And just to give you an idea, a quarter teaspoon of Morton's iodized salt has 500 milligrams of sodium. Okay, so a quarter teaspoon of salt has 500 milligrams of sodium. So if you eat a whole teaspoon of salt on something, there's your 2 grams of sodium for the day. So canned soups are the absolute worst. So tell patients, try to avoid those. Campbell's home-style chicken noodle condensed soup, where you have to add a can of water. And basically it says that once you add that can of water, there's about 2.5 servings in the can. Well, you eat the whole can. I mean, it's nothing but water. But basically, if you follow the instructions, 2.5 servings, each of those servings has almost 900 milligrams of sodium. It's about 840, I think. So if you eat that whole can of the Campbell's chicken noodle condensed soup, there's your 2-gram sodium diet, clearly more than the 15. So I tell patients, avoid the salt shaker, and it doesn't matter. And my medical students will laugh at me when I say this. It doesn't matter whether it's salt, kosher salt, iodized salt, sea salt, because everyone says, well, sea salt is good for you. It's okay. It's still sodium chloride. Whether it's seasoning salt, I have little ladies say, oh, honey, I don't use regular salt. I use seasoning salt. It's still salt. Or I don't use regular salt. We use sea salt. Still sodium chloride. So I tell them if it says salt, stay away from it. Onion salt, garlic salt, celery salt, stay away from it. Stay away from the canned soups. Anything that's processed, that all you have to do is, open the can, open the package, warm it up, it's going to be much higher in sodium. The frozen TV dinners, Healthy Choice and Smart Choice aren't too bad, but Weight Watchers. Weight Watchers is loaded with sodium because they pull the fat out because you want to lose weight. But if you take the fat out, how do you make it taste good? You boost the salt. So Weight Watchers is loaded. And those are kind of the big ones. And then bread. If any of you bake, bread actually has a lot of salt in it. And so we really talk about bread with our heart failure patients. So just being aware of food content and what to avoid. I always tell like our clinic patients, if you can go to Aldi, which is one of our grocery stores, I don't know if y'all have that here. But if you can go to Aldi's and get 10 cans of green beans for $1, you're going to get 10 cans of green beans for $1. because you can get that 10 cans instead of buying a pack of frozen that's going to cost you $3. Well, if you have to get the canned green beans or green peas or corn, pour the water off that it's packed in, rinse it, put fresh water, add other seasonings, and you can still, have the canned vegetables, but you do get rid of some of the salt and sodium when you do that. Okay. Physical inactivity. The recommendation is on average 30 minutes a day of moderate aerobic activity. So that's, exercising to a point where you get your heart rate up. Walking is good exercise, but you have to walk at a pace where you feel it. So what I tell patients is that if you're walking with someone or on your phone, if you can walk and talk at the same time, you're not walking fast enough. So if you're walking with a buddy and you're just carrying on this conversation and y'all are just chatting away for that whole 30 minutes, you're not walking fast enough. Or if you're on your cell phone and you can walk and talk, you're not walking fast enough. And I'm sure you guys have noticed it, if you're on your phone and you're in a hurry to get to your car, if you're trying to talk and hurry at the same time, when you get there, you're getting a little bit winded. Okay, think about doing that for 30 minutes. So if you can walk and talk, you're not walking fast enough. But walking is good exercise and it's free. Okay, you don't have to have a treadmill, all that kind of stuff. Low fiber, high fat diet, okay, basically more fruits and vegetables in the diet. And then heavy alcohol ingestion. So this is always a good one. Because here the recommendation is more than 2 drinks a day for a man or 1 drink a day for a woman. That's the recommendation. So when patients tell me, I drink, and I say, how much? Not that much. Well, what does not that much mean? Socially, what does that mean? And then they tell me, well, I have 3 beers a day. That's a considerable amount. But I did have a guy tell me that once. We were talking about alcohol, and he said, I don't drink that much. And I said, well, what's not that much? He goes, not that much. Okay, what's not that much? He goes, well, it's not like I'm an alcoholic. And I said, well, if you buy a case of beer, how long does it last you? And he was a manual laborer, and he said, well, when I get done with work, I sit on the truck with the guys and have about 3 beers in the afternoon, and then on the weekends I drink about 3 15-packs. My first thought was, I didn't realize beer came in a 15-pack. The medical student with me said, well, if it's a 15-pack, it's not a 12-ounce can of beer, it's the 20-ounce. And then I thought about it, 3 15-packs. That's 45 cans of beer. That's 2 cases, almost. But in his mind, that's not that much. So when they say not that much, make sure you're not that much and the patient's not that much is basically about the same. But these are, some of the factors that do contribute to resistant hypertension. And just try to make sure you address it with the patient. And you'd be surprised. Lowering the sodium intake, cutting back on the alcohol, losing weight, and increasing exercise really does help lower blood pressure. And it really does work. It's hard because those are lifestyle modifications, which are behavior changes, which it's hard for people to do. But if they can really engage in that, you really can see a difference in their blood pressure. Okay. So looking at the risk factors, and what time was it? 1:20. What time? 2:20. 2:20. What time? 2:45. So 25 more minutes. Okay. All right. So we already talked about this. This is blood pressure control not being that great. So there's some things that in Black patients in particular. So the question here is, what is it about hypertension in Blacks that makes it a little bit more difficult to control, makes it come on earlier in life? And some of it is physiologic, and then some of it is social. So clearly, obesity is a big problem, particularly among African American women. Blacks tend to have higher salt sensitivity, so more sensitive to the sodium that you get in your diet that raises the blood pressure. And as a result of that, some of the blood pressure medicines, like the diuretics and the calcium channel blockers, actually tend to work a little bit better in Black patients. Renin, which is a hormone that comes from the kidney, those levels tend to be just a little bit lower, so that contributes to some of the changes that we see. And then some other changes in blood pressure function, other associated comorbidities, particularly like diabetes and chronic kidney disease, physical inactivity. And we can't put enough emphasis on the role of family history, okay? If hypertension runs in the family, it tends to just continue to run in the family. The Institute of Medicine actually identified these 5 risk factors that contribute to the bulk of hypertension problems, and I've actually kind of gone through these, but simply being overweight, eating an unhealthy diet, lacking physical activity, a high sodium intake, and low potassium. Potassium in the diet is something that's not talked about a lot, but potassium and sodium actually go together because you really have to have good potassium levels and a normal potassium intake to actually counteract some of the sodium as well, and that's just kind of from the kidney standpoint. So we always talk to the patients about making sure that they're eating a potassium-rich diet as well, which if you're eating more fruits and vegetables, you're going to get the potassium. So we always hear about bananas and orange juice, but apricots, avocados, a lot of the beans, lentils are good sources of potassium. Tomato juice is a good source. I shy away from telling people tomato juice because it's high in sodium as well. But there are a lot of other molasses, blackstrap molasses. I actually had a patient say, ooh, blackstrap molasses, I love blackstrap molasses. I've never even seen it in the store, but that has a very high potassium content as well. But making sure patients are getting good potassium in their diet is very important as well. And I don't have to go through these, as much, but, obesity. I think Time Magazine had a cover article around 2007, 2008, really talking about the obesity epidemic in adults, and then not long after that, they ran another one that talked about the pending obesity epidemic in children as well. So we've definitely become a more obese society, and as a result of that, we see more, hypertension and diabetes related to that as well. Physical activity of those who meet the recommended guidelines, it's somewhere between 15 to 23%. Most adults do not exercise on a regular basis, and this is, you see black patients in red and whites in the green. So we have a lot of work to do as far as getting people more up and active. And this is just basically talking about prevention. If we could get folks to buy into prevention earlier, get our health systems to start really promoting prevention, paying for preventative measures, we could stave off a lot of these complications that we see related to cardiovascular disease. Sodium and potassium, I kind of mentioned that, trying to consume 1,500 to 2,000 milligrams of sodium a day, making sure there's adequate potassium in the diet as well. And here it says only 2% of U.S. adults meet current guidelines for dietary potassium intake. So that's something we should work on. So, this is a question about drug therapy. Which of the following statements is false? Monotherapy with thiazide diuretics is considered similarly effective to long-acting calcium channel antagonists for lowering blood pressure among black patients. That's actually true. And if you look at the guidelines, the first-line therapies that are recommended are thiazide diuretics and the calcium channel blockers. Mexican Americans are less likely to be aware, treated, and have blood pressure control when compared to whites and African Americans. That's actually true. That was one of the first slides that I showed you. Hydrochlorothiazide and chlorthalidone, 25 milligrams, are similar in blood pressure lowering ability. That's actually the one that's false here. So if you're familiar with the drugs, hydrochlorothiazide and chlorthalidone are both thiazide-type diuretics, but this 25 of chlorthalidone is actually going to be a little bit more potent than the 25 of the hydrochlorothiazide. And then spironolactone is a good agent to add for blood pressure control with resistant hypertension. And that's actually true. Most folks think about spironolactone for heart failure patients, add-on therapy for heart failure. But spironolactone was a blood pressure medication before it was a heart failure medication. And there are numerous studies now that have shown that in a resistant hypertensive population, if you add spironolactone as the fourth drug or the fifth drug, you see a marked decrease in blood pressure. So I use a lot of spironolactone in my practice. The limiting factors are kidney function and potassium levels. If they have chronic kidney disease, that's going to prohibit its use, or if they have hyperkalemia, that's going to prohibit its use as well because, spironolactone makes you actually hold on to potassium. All right, so how do we close this gap? Recommended treatments. I already went through the lifestyle things a couple of times, so just making sure active weight, heart-healthy diet, low-fat, low cholesterol, low sodium, adequate physical activity, and making sure that they're not drinking too much based on your recommendation of not what too much. Medications, thiazides, calcium channel blockers, initial therapy in African American patients. Now, diuretics reduce blood pressure, stroke, heart failure, and overall cardiovascular disease risk. And that's one thing, and chlorthalidone is the diuretic that actually has that data. And that's why there has been some push for us to use more chlorthalidone in our treatment for blood pressure. Because when you look at outcomes, chlorthalidone has consistently been shown to reduce particularly stroke as patients get older when you treat for blood pressure. And that's data that we don't actually have with hydrochlorothiazide. But then bottom line, get the blood pressure under control. So if they need more agents, you're going to add those agents appropriately. But we do have good data with thiazide diuretics, calcium channel blockers, and with the ACE inhibitors in particular. This just shows some blood pressure reduction. And what you see here is that for whites, whether you use a diuretic, calcium channel blocker, beta blocker, or ACE inhibitor, the amount of reduction is about the same. But clearly in blacks, you see greater reductions with the diuretics and the calcium channel blockers. Now, we talked about resistant hypertension. Patients are going to require more than one drug. So basically, if you're treating a black patient, you want a diuretic and a calcium channel blocker on board, but you're probably going to have to use the ACE inhibitor and the beta blocker as well. But just beware, if you're looking for that first drug, and you're only going to start them on one drug to start with, unless they have some compelling indication, like atrial fibrillation, or they've had a heart attack and need to be on a beta blocker, you're not going to get their blood pressure under control with the beta blocker by itself. So I tend to add diuretic calcium channel blocker, usually in combination with an ACE inhibitor, and my beta blocker actually tends to be about the 4th or 5th drug that I use, because I'll often use spironolactone before using a beta blocker, particularly if they don't have an indication for the beta blocker used, like coronary disease or heart failure. And this just shows the addition of spironolactone when you add it. And these studies consistently show that when you add 12.5 to 25 milligrams of spironolactone to baseline therapy that includes a thiazide diuretic, an ACE inhibitor, or a calcium channel blocker, you can see anywhere from a 22 to 28 millimeter reduction in systolic blood pressure and 10 to 13 millimeter reduction in diastolic blood pressure. So don't forget about spironolactone for those patients with resistant hypertension. Combination therapy is really what we're talking about. Very few patients are on monotherapy for their blood pressure anymore, particularly if our goal is to get them below target and to keep them there. Okay, so consistent 24-hour control. Really kind of talking about secondary prevention, that the goal is to reduce cardiovascular events. All right. Now, how do we overcome some of these obstacles to the disparities? And this is where we get into talking about barriers, cultural competency, and a little bit more into some of the strategies, outside of medications for decreasing this gap. So what are some of the barriers to blood pressure control? They exist at 3 levels: patient levels, physician levels, and system levels. Patient levels, a lot of times there's a lack of trust. And you see that a lot in the African American communities. They don't trust the healthcare system. Okay. You're telling me to take all these pills? Really? Well, my friend down the street tells me that if I use vinegar and garlic, I'll be fine. You're giving me these medicines, you know what I mean? So there's a lot of holistic beliefs as well. So trying to find out, actually talking to the patients, what are some of the concerns you have? Do you have other beliefs? Are you doing everything at home? Try to address some of those barriers. Physician levels. Make assumptions about patients. Just because I look like an African American woman, am I really an African American woman? Maybe I'm part African American and I'm part something else. So a lot of times, just kind of see someone, we make assumptions about them that may or may not be true, but those assumptions guide how we treat our patients and how we interact with them. And then system levels. Here we get into healthcare costs and access to care and so forth. Improving cultural competency, understanding the critical importance for cultural relevance, developing a deeper understanding of culture, cultural behavior, patterns, beliefs, expectations. So understanding where your patients are coming from, basically. Because it may not be that they don't trust you or they don't not want to do what you're telling them. There may be some cultural barriers that are standing in the way that just need to be discussed and sorted out. You don't know that unless you try to understand the background of where that patient is coming from. So again, some of the patient-related barriers: poor knowledge about hypertension and its consequences, adherence to medication, false health beliefs, inability to change one's lifestyle. You know, kind of the thing, you talk about, you know, if you sit there, so you know what, you've got to eat fresh fruits and vegetables. They may not tell you, I can't afford fresh fruits and vegetables. There's no place in my neighborhood to get fresh fruits and vegetables. But there's the Aldi down the street and the $10, you know, 10 for $10 green beans, okay? They may not tell you that. I always get suspicious with my older patients when I get a flag from the pharmacy about prescription refills. You know that donut hole they fall into? Patients don't tell you they're in the donut hole, and they start splitting their medicines. You know, they can't afford to get them. They don't tell you they can't afford it because you might be able to help them with samples or give them something that's cheaper, but they start taking their meds every other day to make them last. And you're wondering why their blood pressure or their diabetes has gone out of control. Side effects to medications, you know, side effects they're there. Being upfront with the patients about that. Unrealistic expectations of treatment. Letting patients know hypertension is not curable. Diabetes is not curable. These are chronic diseases that have to be addressed as time goes on. And then understanding the socioeconomic education levels and age as well. Physician-related barriers. Failure to recommend treatment. Non-adherence to evidence-based treatment guidelines. If you don't know what the guidelines say, you know, using that beta blocker by itself in a black man who has a blood pressure of 160. It's not going to get his blood pressure under control, and also I'm going to guarantee he's not going to take it, because the beta blocker by itself is probably going to have some sexual dysfunction. Okay? Failure to increase the drugs as indicated when needed, and failure to emphasize therapeutic lifestyle changes. Don't assume that patients aren't going to do it, because sometimes you'd be surprised who actually will take it to heart, and you really can see the changes in their blood pressure. Why is cultural competence important? It's one of the main drivers in eliminating health disparities. And this is all from an Institute of Medicine report that was published back in 2004 that looked at these issues of trying to get to why some of these disparities exist. It fosters meaningful learning where patients and doctors can come together and talk about health concerns without cultural differences hindering the conversation, but enhancing it. And healthcare services which respect and respond to the health beliefs, practices, and the cultural and linguistic needs of diverse patients can result in positive health outcomes. So again, basically understanding where your patients are coming from. Cultural and linguistic competence is a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals that enables effective work in a cross-cultural situation. Culture refers to the integrated patterns of human behavior that include their language, their thoughts, their communication patterns, beliefs, you know, basically what's, you know, around their social group. And competence implies having the capacity to function effectively as an individual or organization within the context of the cultural beliefs, behaviors, and needs presented by those in the community. Again, getting to know where your patients are coming from. So some of the predictors associated with lower medication adherence are African American race, female sex, and treatment at a publicly funded or primary care clinic, which is often a marker of low socioeconomic status. So sometimes other measures have to be put in place to help with compliance to medications. Several studies have shown that a lot of times patients will take that first prescription that they give you, but then the refill rate after about 6 months just markedly drops off at that point. So this is what was recommended as 8 dimensions of patient-centered care. Respect for patients' values, preferences, and expressed needs. Have a conversation. Coordination and integration of care. I think our electronic medical records does help with that to some extent. Providing more information and education to the patients. Physical comfort, emotional support, alleviation of fear and anxiety, access to care, still need to work on, involvement of family and friends. Sometimes, particularly with men, and this is particularly true with black men, you have to involve the woman in their life, whether it's their spouse, their sister, or their mother. I think if they're grown, but you know, it's the females that drive healthcare in black families. And then continuity and transition, making sure there's continuity of care if there's a change that's communicated clearly. So what can you do? 6 steps to improving patient understanding. Limit the amount of information provided at each visit. Keep it straightforward, and often ask patients to reiterate, what I've told you. What are you going to do to make sure that they're clear? Slow down. That's a big complaint I hear from patients. Well, she told me so fast and was out the door, I didn't get a chance to ask a question, so it really wasn't clear at all. I didn't know what to do. Avoid medical jargon. Just keep it straight and simple. Lay terms. Use pictures or models to explain concepts if needed. Assure understanding with the show me technique, reiterate that. And encourage patients to ask questions. That's probably the biggest complaint again that we hear. Patients just say, I didn't have time to ask my question. And therefore nothing gets done. So thank you very much for your time. Does anyone have any questions?
I noticed on several of the graphs that the American Indian was in the same basic ballpark as the African American. I used to work on a reservation for 2 years in Nevada. I'm assuming it was probably diet, activity, and alcohol. Do you think that that's correct? And if so, it wasn't even mentioned, are we doing anything for them as well? Or do they not comfort care? What, could you speak to that?
So her question is about the American Indian population, that a lot of the rates were similar to African Americans, and a lot of that is social, diet, alcohol is a big problem on the American Indian population. So it is being addressed to some extent, and it's primarily being addressed from the standpoint of diabetes. Okay, so that's where most of the focus has been. But most of the information that I've seen is that there isn't a lot of information. So that's why some of the slides are incomplete. You see, American Indians on some of the slides and not on the others, because we actually need more information from that population. And a lot of it has to do with they don't access to care, get into care. So it is something that is aware. Now, in our diabetes prevention program study, we actually have a site that's in Nevada that was specifically to try to capture American Indians in that study. And so unless you deliberately look at that population, whether it's hypertension or cardiovascular disease, you're not going to find them in studies, you're not going to find a lot of data, and what's there is going to be incomplete. So it's clearly a gap that we have that needs to be addressed more. I think, did you have a question?
I was just curious, a lot of these communities have a very low African American population, smaller communities, but I found it kind of surprising that I guess I never thought to target the African American woman versus the man. I think typically you go after the male population thinking they're less compliant, they don't seek help, more the ego behind the male than the female, but your data says otherwise, that you need to almost target women for their compliance, and especially if they're kind of the nature of your household, that they should probably be a better target audience, because you probably disseminate compliance from there.
Right.
I don't know, what are your...
So it's kind of a two-way street. Women come in, okay, so we probably have more data on African American women, although we need more, because if you actually look at studies, they're actually underrepresented in studies. But African American women will go to the doctor, they'll get screened, they'll, so forth. Hypertension is very prevalent in African American women, and so is diabetes and obesity. So that's why we see their numbers look worse. The death rates in African American men is actually pretty significant because they don't come in. But if you want to get to the African American male population, you get to them through the women. So it's kind of a two-sided street. You've got Black African American men and African American women who are both at significant risk. How do you get to one population? You can pretty much tell the woman to come in, so we have numbers on her, but you got to get her to get the man. So they both need to be addressed. Yes, ma'am?
Are you familiar with the no salt salt?
No salt salt. So no salt salt, if I'm thinking about what you're thinking about, actually isn't really no salt. It's about 50%. It has potassium chloride in it. Right. It's potassium chloride. And I actually don't recommend it to my patients because what happens is even though it's lower in sodium, they tend to use more of it. And so by the time they add more of it, you're back up to where you were. And then I've tried one of those versions, and the more you add, to me, it gives a bitter taste. So I don't recommend it at all because I think you get in the habit of using it, you just use more and more until you get that taste that you want. I will say that for sodium, if you really, really cut back on sodium for 21 days, and that's really all it takes, 21 days of following a low sodium diet, your taste buds will readjust. And if you get something salty after that, you can almost not stand it. But it takes about 21 days. And I've actually had a couple of patients who took me up on it and tried it, and they've actually come back and said, wow, you were right. I really cut back on sodium, and then I ate whatever, and it was really, really salty. But if you can just get them to do it for 21 days, it makes a difference. Yes, ma'am.
I just started a project with a barber shop in our